So our next speaker is Ashwani Kumar. Ashwani is a physician with over 12 years of medical research experience. Currently he's pursuing a doctorate at Critical Care and Trauma Division of the George Institute for Global Health, which is affiliated with ASW. And he's going to be talking today about near twofold rise in ICD-Coded Sepsis-Related hospital admissions in Australia and an Australian Institute of Health and Welfare database analysis. Thank you.
Yeah, thank you very much. Thanks for the opportunity. I'll just, you have done this, so I can skip this very quickly. Yeah. So that's a team at the George Institute which are involved in this study. I would like to specify the name of Manoj, Naomi, and Coleman, which provided very specific inputs in this study. Now, this image on this slide really sums up the sepsis and dilemma around sepsis. Sepsis is not a disease per se. There is no diagnostic criteria to identify sepsis, and there lies the problem. But if we had to go to the definition as per the recent Sepsis 3 guidelines, it is an life-threatening organ dysfunction induced by infection. And organ dysfunction, as per the Sepsis 3, is by the criteria for that is more than 2 or more increase in SOFA score. Now, that sepsis, as we know, is associated with significant mortality and morbidity. Globally, there are about 30 million cases identified every year, and out of which 6 million die. And in the US alone, about 24 billion gets spent to treat sepsis in ICU, and we are not even talking about outside ICU management. Now, as I said, in the absence of diagnostic tests, the clinical identification of organ dysfunction and infection remains a mainstay. But in population, to identify the true disease burden of sepsis, the ICD codes remain the most practical method to identify or to estimate the disease burden. Globally, for various reasons, the true disease burden remains poorly understood, including Australia. And in 2017, WHO identified sepsis as the global health priority and also the improved use of ICD coding to identify sepsis burden. Just a few words about AIHW. Now, AIHW, as we know, is the leading Australian welfare organization which maintains various hospital admission data sets which are fed by each state around, and these are both aggregated data set as well as episode level data set. And that's why we decided to use AIHW hospital admission data set, because it gives an idea about trends in Australia in the last few years. And again, how ICD codes are assigned to these various medical conditions, including sepsis. We have trained medical coders in each hospital, and they use a very standard methodology to assign disease-specific sepsis code. And it largely depends on the medical notes that they do the medical chart review, and accordingly they assign the ICD codes. So we did this study to estimate the incidence and trends of sepsis-related hospital admissions in Australia between 2011 and 16 using ICD-10 sepsis codes. It was a retrospective analysis of publicly available aggregated data sets. So for this study, we used only the aggregated data sets. All hospital admissions were included, which were related to sepsis between 11 and 16, and a descriptive analysis has been presented here. For case identification, we used the following sepsis-specific codes, and as we know, let me go back. Yeah. So this method is called explicit criteria because only codes which are specific to sepsis were used to identify sepsis-related hospital admissions. In terms of key results, there were about 29 million hospital admissions in 5 years period, and out of those, slightly more than 130,000 had at least one sepsis code, which accounts to an incidence of 4.5 per 1,000 hospital admissions. And there was an upward trend was seen during this 5 years period, and half of those admissions related to sepsis were due to non-specific sepsis, which shows that still we don't know the clear etiology behind the sepsis as a syndrome. Now, this slide is showing the total number of sepsis-related hospital admissions, and as we can see, the number really doubled in this 5 years period, from 19,000 to close to 37,000. But number can be misleading. So what we did was we calculated the incidence and and the story remains the same. The incidence increased from 3.6 to 5.9. And interestingly, there was a big jump between 2014-15 and 15 and 16 years, which was about 30%. Now, looking at the major sepsis code related to, and we essentially had 4 major codes. First was A41.9, which was unspecified sepsis, then was gram-negative, staph, and strep. And as we can see, the number of unspecified sepsis increased more than 2 times in the 5-year duration. And others also increased, but not in that proportion. And this slide is about the proportion of each of those major sepsis code. And as we can see, now the picture slightly changed here. The proportion of unspecified sepsis increased over the time, while the others either remained the same or decreased. So this is about length of hospital stay and how it fared between those 5 years. And as we can see, there was no clear trend. And on an average, the hospital stay was 10 days, which is quite significant. Some critique strengths and weaknesses. As I mentioned, the reason we picked AIHW dataset because it gives a bird's eye view on Australia level numbers around sepsis. And they have their due diligence in place, so we knew the data dataset will have of good quality. But having said that, the challenge of limitation with this dataset was because it was an aggregated data, we really couldn't do, we didn't have any episode level information to analyze. We didn't have any mortality specific information. We didn't have related to ICU admission or mechanical ventilation. Just to conclude, there was an upward trend in sepsis-related hospital admission in Australia between 11 and 16. And this was driven predominantly by a 20% increase in the proportion of unspecified sepsis-related hospital admission. Now, in terms of next step, what we plan to do, we want to apply for an episode-level access to AIHW, which will allow us to do an analysis as per the clinically relevant parameters, such as mechanical ventilation duration, ICU admission, etc. And we will extend the duration to 10 years, to 2007 to 17. Thank you.
Any questions from the audience? I have a question then. Do you think this is, it's real, or is it just an artifact from coders changing the way that they code sepsis? Is it, and if you think it's real, what could be the cause? Do you have any ideas of what's causing it?
So it's a combination of, yes, you're right, it is being coded increasingly, and the awareness around sepsis is increasing, and especially outside ICU, it's not much, it is still a disease or condition which is identified by intensive care physicians, but more and more doctors are now getting, especially after WHO resolution, there is a campaign around the world to identify sepsis. So I would say it's a combination of both.
So it's more the medical staff are recognising it.
Yeah.
Thank you. My question is, have you seen an effect of the change in the sepsis definition since the last conference?
So that could potentially explain the rise of 30% between 14, 15, and 16, because Sepsis-3 introduced the concept of SOFA and used that as an objective measure to identify sepsis. So that could potentially be the reason. Yep.
Do you know if that's this sepsis and the change with the SOFA score now being implemented? Do you think that this has been reinforced with the coders? Like, has the coding changed, or is it still being used in the same way?
Yeah. So the coding, how the medical coder work, they do the medical chart review. So it essentially depends on how the physicians are documenting sepsis. So in my view, because that has changed after Sepsis-3, and that is leading to the change in coding practices.
You've got time for more questions. Anyone? Yep.
Yeah, look, it's just a question about whether this is an accurate way of getting a handle on the incidence of sepsis, or what could we do better to get an estimate of the real incidence of sepsis?
The gold standard remains the clinical identification of sepsis, so doing the medical chart review and really doing a comparison of the sepsis identified by medical chart review, clinically identified sepsis case, and then comparing it with an ICD coding method. And that's what we plan to do in another study, which will give us the real sense around true sepsis disease burden. And this really gives you account on Australia level how sepsis coding practices, and as the point raised, and how it is getting affected by, for example, change in sepsis definition.
Any other questions? Right. Should we move on? Thank you very much.
Thank you.